So shall we start?
Yeah.
So are you ready?
Yes.
Yeah. Durga, please start.
Yeah, yes. Good evening, doctors. On behalf of Lupin, I welcome you all for today's ePedia talk, that is ECME for Continuous Medical Education Program, conducted by Lupin. Doctor, are you aware that in present scenario, management of pediatric illness is a challenge, and especially the management of asthma attack in present pandemic is also one of a challenge. So today, on behalf of Lupin, I welcome Dr. Suresh Panuganti to share his experiences. Before I hand over to Dr. Suresh Kumar, I would like to introduce you all to Dr. Suresh Kumar. Dr. Suresh Kumar is a senior pediatric intensivist from Nice Hospital, Hyderabad. Dr. Suresh Kumar holds a fellowship in pediatric critical care from UK, and Doctor has done his fellowship in pediatric critical care in UK, and Doctor has done diploma in pediatric and child healthcare from Imperial College from London. And Dr. Suresh Kumar is an author of various chapters in national and international books in sharing his experiences. With this introduction, I would like to hand over the session to Dr. Suresh Kumar. Dr. Suresh, it's over to you, sir.
Yeah. Good afternoon, everybody. Thank you for the introduction. Without wasting much time, we'll just move on to the topic per se. Management of asthma exacerbation or an asthma attack during the pandemic. So asthma is one of the most common chronic disorders in children across the world. More than 33 crores of children have been living with asthma across the world, and nearly 80% of asthma related deaths occur in low and lower middle income countries. But having said that, it is still common to see a death due to asthma even in so-called developing worlds across the world. So COVID-19 has wreaked havoc across the globe, and then the entire world is having to reevaluate almost every aspect of our daily living, which we took granted in 2019. And it raises two pertinent questions. What has COVID-19 taught us about asthma in children, and what are the implications for management of asthma in children? So these are the two most common questions, and let's get to the point. And addressing the management of asthma in the era of pandemic is very crucial. The prevalence of asthma in India is high. Having said that, during the COVID-19 pandemic, not only the frequency of exacerbations of asthma have changed, but also the management of asthma has been transformed. Virtually, almost routine checks in secondary and tertiary caves have been being monitored remotely. And another factor could be striking reductions in atmospheric pollution. We all have seen the months of lockdown during which there was a very, very minimal or negligible amount of atmospheric pollution, which is a very well established factor in causing asthma exacerbations. And also the third point could be the entire family has been living at home. So there could have been a better parental monitoring and supervision of asthma related medications, thereby increasing the compliance. Thus, it could be a crucial factor that it would have reduced the exacerbations. And something which we have never seen in recent history, that is social distancing and quarantine practices, not just in India, but across the world. We have seen these practices which were unprecedented in recent history. And there have been, on the flip side, there have been reports which have described that there is enough significant mental strain, such as anxiety, fears, and depression, and also leading to obesity, which in itself is a risk factor for asthma, either directly or indirectly. The societal challenge is that the majority of these reductions in exacerbations have been achieved with no new or expensive drugs, but just by behavioral changes. That should be taken as a positive point. And differentiating asthma from COVID-19, over a period of time, there have been increased in incidence of COVID-19 in adults who were suffering from asthma. And it's not always easy to differentiate between COVID-19 and an exacerbation of asthma, especially in adults. If you look at the differentiating features, the length of symptoms in asthma. Can I request the moderator to keep everybody in mute? Yeah, thank you. The length of symptoms in COVID can last from 1 to 4 weeks. Having said that, again, in pediatrics, we are seeing a lot of post-COVID syndrome, that is MISC, which can affect any part of the body. Whereas in asthma exacerbations, it can start very quickly and then progress or deteriorate rapidly. Dry cough is very common in COVID symptoms, whereas in asthma exacerbation, usually it is dry or it can even be productive. Wheezing is very, very common in children with asthma, whereas wheezing is not very common in children presenting with COVID-19. Breathlessness can be seen in both, especially in severe forms of COVID, we can see breathlessness, but in exacerbations, most of the time we see breathlessness. These are a few points which I would like to highlight while we are differentiating asthma from COVID-19. And heterogeneity of asthma and potential risks of COVID-19 in severe form. The risk of severe COVID in subjects with asthma is influenced by multiple factors, which includes demographics like age and gender, ethnicity, genetics, and the treatment options on which they were on earlier, like inhaled corticosteroids, and the severity of asthma per se, and the lung function prior to this exacerbation, and the compliance and adherence to treatment, and the level of control the child's asthma was prior to this exacerbation, and then the frequency and the asthma phenotype. There are two asthma phenotypes. If you look at the table, I will just go in detail in a minute, and the other one is inflammation and comorbidities. If child has certain comorbidities, they are at a higher risk for developing exacerbations. So if we try to differentiate them based on the characteristic of asthma, children and adolescents are prone to have slightly lesser risk of COVID-19 as compared to elderly people. Whereas type 2 asthma phenotype, that is intrinsic, and there are two types. One is extrinsic and intrinsic. Extrinsic is non-atopic and intrinsic is atopic type. And then if an asthmatic child develops COVID, they are prone to have lower interleukin levels as compared to an asthmatic adult. And then if child's lung function is better, they are prone to less prone to have COVID infection as compared to a child whose lung function is not normal. And then if the child is having a well-controlled asthma, he is less likely to develop COVID-19 infection as compared to a child who is uncontrolled asthmatic. And then a child who is on inhaled corticosteroids is less likely to develop exacerbations or is considered to have a decreased risk as compared to a child who is only on oral corticosteroids. And then this is just assessment of asthma in children 5 years and younger. This is taken from GINA guidelines. I would just quickly rush through this in major headings, that is symptom control. We need to look at few points among symptom control. How is the child over last 4 weeks? Did the child have any daytime symptoms? If so, how many minutes it lasted? And if so, how many times in a week? And then how is the activity? Is it limited or is it normal? Is the child able to run or play as he was doing earlier, or is it decreased? And has the child required any relieving medication more than once a week? And then is the child having any night walking or night coughing due to asthma? And then based on this, if child does not have any of those, that says that child's asthma is well controlled. If child has one or two of those 4 symptoms mentioned above, it is considered as partially controlled. If child has 3 or 4 of those, it's considered as uncontrolled. And what is the future risk of poor asthma outcomes? They are subdivided into risk factors for asthma exacerbations and risk factors for persistent airflow limitation and risk factors for medication side effects. And then it is slightly different in older children, that is 6 to 11 years. And asthma control, similarly, in last 4 weeks, we are going to ask a few questions, that is whether child had any daytime symptoms more than twice a week, whether child had to wake up in the night, whether child required short-acting beta agonist for symptom relief more than twice a week, or is there any limitation of activity due to asthma? Similarly, if all of them are absent, it is well controlled. If 3 or 4 of them are there, it is uncontrolled. Then what are the risk factors for poor asthma outcome in these children? We need to assess the risk factors and diagnosis, and then we need to reassess periodically, especially in children who are prone to have exacerbations. We need to measure forced expiratory volume at the beginning of the treatment, and again repeat at 3 to 6 months, and then we need to give an asthma diary to the parents, and then look at any of the risk factors which are mentioned in the table, like medications or comorbidities, especially obesity, gastroesophageal reflux disease, which in itself is a differential diagnosis for asthma. And if child has other comorbidities like food allergy, and then what is the kind of exposure the child has, whether he has any exposure to passive smoking, or whether he has continued exposure to allergen sensitized, if sensitized, and the air pollution, and how is his lung function prior to this. If child has low FEV1, especially less than 60% of predicted, or whether child has any reversibility. These are the things we need to take into consideration, and there are certain risk factors for persistent airflow limitation, which can start from birth. That is, if a child is born preterm with a low birth weight, and then if child continues to have hypersecretion of mucus, and then if child is not getting adequate inhaled corticosteroids, and if child continues to have passive exposure to smoke or occupational exposures, and then the lung investigation showing low FEV1 or blood showing hypereosinophilia. And the risk factors, the checklist of factors that can influence patients' asthma control, to put in a nutshell: one is the technique, the environmental triggers, and individual triggers. Certain modifiable ones are environmental triggers, and most common one in winter and rainy season is viral respiratory tract infections, and most common viruses which are implicated in triggering an exacerbation is rhinovirus and RSV virus, that is respiratory syncytial virus. And what is an exacerbation? Basically, because of exposure to either intrinsic or extrinsic factors that can trigger an acute attack, which is otherwise called as exacerbation. Exacerbation of asthma is an episode which is characterized by progressive increase in symptoms like shortness of breath, cough or wheezing, or chest tightness, and which will result in progressive decrease in lung function. That is, they represent a change from the child's usual status that is sufficient to require a change in treatment. It can occur in a child who is already diagnosed asthmatic, or it can be the first manifestation of child with asthma. And common triggers for exacerbations, like I told in the earlier slide, is viral respiratory infections or allergen exposure, food allergy or outdoor air pollution, or seasonal changes, especially when they change from summer to winter or rainy to winter or winter to summer, they can have. And most common triggers are RSV and rhinovirus. And due to COVID pandemic, with regard to COVID pandemic, there is some evidence today to suggest that asthma is overrepresented amongst adults who have been admitted with COVID-19. This overrepresentation may occur because COVID virus triggers exacerbations as other viruses do as well. That's the reason why CDC has listed asthma as one of the risk factor for morbidity and mortality associated with COVID-19. Royal College has raised concerns about children presenting very late to hospital during COVID pandemic, and hence it is very, very relevant that exacerbations are managed aggressively during the first hour of presentation. In children, it can be fatal. It can occur in an asthmatic child or as a first presentation, as I mentioned earlier. In children, if it is not controlled or not treated appropriately or early on, it can be fatal. And frequent exacerbations result in very poor quality of life. It can result in school absenteeism, which can lead to the potentially adverse impact of the child's lung function over a longer period of time. How do we manage the acute asthmatic exacerbation during COVID? We are not going to details about all management of asthma, that is mild, moderate, or severe, and all those things. We are only going to talk about exacerbations. So it can be dealt under 4 major side headings. That is, what are the symptoms of acute exacerbations? Like I mentioned earlier, the child will have progressively worsening wheeze or increasing cough, shortness of breath, or limitation of activity. It can impact child's routine activity like feeding or sleep habit. And we need to look at the home management of asthma in a written asthma action plan based on the child's status prior to this exacerbation, whether child has been receiving appropriate drug, appropriate dose, appropriate duration, and appropriate delivery device. And then how do we manage acute exacerbation at an acute care facility which has got both emergency room as well as ICU? And what do we do for follow-up after exacerbation? We are going to see this in next few slides. And there has been enough debate which was triggered based on nebulized bronchodilator therapy during COVID pandemic. It has resulted in stringent infection control measures, including use of full PPE while using nebulized bronchodilators. What have various societies mentioned? The utilization of nebulized therapy potentially increases the risk of aerosolization of coronavirus. This was the initial statement which was passed. Subsequently, the British Thoracic Society has suggested that the nebulization as such do not cause droplet generating, because it is the machine which is generating the droplets. It is not on the patient end. So the advice from Public Health of England is that nebulization is not a viral droplet generating procedure, whereas the droplets are generated from the machine using liquid bronchodilator drug. So since nosocomial transmission of respiratory pathogens is a major threat in the context of COVID, so use of nebulized therapy should still be very careful, especially if there are concerns that it can increase the risk of transmission to the other children or other patients who are admitted in the same unit. So we need to have a risk stratification plan which should aim at reducing the nebulized therapy by using other appropriate devices like pressurized meter dose inhalers wherever it is possible. And protocols should also include strategies which will allow some flexibility as to when to use MDI versus when to use nebulization. So any child presenting with an asthma exacerbation with low saturation as described by less than 92 in room air should receive nebulized bronchodilators as per BTS guidelines, which we will deal in detail in next few slides. Moreover, in children who have severe wheeze and saturation less than 92 and severe respiratory distress as evidenced by use of accessory muscles, the efficacy of nebulized salbutamol alone is not sufficient. Child might require a combination of salbutamol plus ipratropium bromide. So a combination therapy with the salbutamol and ipratropium bromide is better as compared to salbutamol alone. And what precautions we need to take? For any child with asthma who is having progressive or worsening symptoms, COVID-19 screening protocols must be used to help determine their level of risk as well as whom we need to test. While this testing is awaited, all healthcare workers involved in administering the nebulized therapy or in and around the child who is being administered should wear appropriate PPE, that is at least an N95 face mask and eye protection, gloves and a gown during the treatment if respirator is unavailable. If that is available, well and good. And try and have the child in isolated room and close the child's door when providing nebulizer therapy. And once the nebulizer is set up, healthcare workers should maintain adequate distance of at least 6 feet, if not more, if possible, outside the door. And remember, child need not be transferred to a higher level just for the need of nebulizer therapy. If we can take these adequate precautions, nebulizer therapy can still be used. And if it is not possible, we do have alternative options. And regarding the use of oral corticosteroids, there was a big hue and cry and debate about oral corticosteroids increasing the risk of COVID-19. But it is proven beyond doubt that if corticosteroids are not administered early on in therapy for acute exacerbation of an asthma, it results in significant morbidity and mortality. Hence, multiple national and international organizations like GINA, BTS have recommended use of oral corticosteroids as required, and we need to keep that as a part of child's asthma management plan as well, even during COVID-19. And how do we categorize the severity of exacerbation? Various societies have given their own ways of categorization. The common one is GINA 2020 guidelines. They have categorized into either mild exacerbation or severe exacerbation. And BTS have got 3 levels of categorization. And if we go into the GINA guidelines, we need to categorize based on 7 characteristics. One is if child has altered consciousness, he falls under severe. And the next one is the saturation, whether it is less than 92 or more than 95. And the third one is speech, whether the child is able to speak in a sentence during exacerbation, or he is unable to complete a sentence and he is able to speak few words or broken sentence. And how is the heart rate? If the heart rate is less than 100 per minute, it's categorized as mild. And in a child who is less than 3 years, heart rate of more than 180 is seen in severe exacerbation. Whereas between 3 and 5 years, the heart rate which is typically seen in severe exacerbation is more than 150. And next comes the respiratory rate and the central cyanosis, and how is the intensity of the wheeze. Note that at least not that all of them are required to be categorized under severe. If any one of those mentioned in the severe category, that is either altered consciousness or low saturation or inability to speak or tachycardia or bradypnea or quite silent chest or central cyanosis. Any of them are present, it is categorized as severe, not necessarily all of them. And levels of severity of exacerbation in children based on BTS guidelines, they categorized into moderate acute asthma, acute severe asthma, and life-threatening asthma. There are some similarities and some differences, but depending on the level of care where we are admitting and treating the child, we can categorize using either GINA or BTS guidelines. BTS guidelines, moderate acute diagnosis. The differential diagnosis for asthma are gastroesophageal reflux and saturations less than 92% and silent chest or tachycardia. If any of those things are there, child needs to be transferred to a higher level immediately. And while waiting for the transport, if we do not have facility to treat in ICU only. If we have facility, start off this salbutamol, 100 microgram MDI, use pressurized MDI which can deliver aerosols with a higher pressure. 6 puffs by pressurized MDI, use with a spacer and mask. If nebulizer is available, 2.5 milligrams of salbutamol, not levosalbutamol, salbutamol. And it can be repeated. Oral prednisolone is quick to administer. It is going to cause less pain and agitation in a child, and it is cheaper option available. If child is not able to drink or feed, we can use IV prednisolone and a standard dose of 2 milligram per kg and a maximum of 20 milligrams for a child who is less than 2 years and a maximum of 30 milligram for a child between 2 and 5 years. And if child is not responding quick enough, consider adding ipratropium bromide 250 micrograms by nebulization. That can also be repeated every 20 minutes for first 1 hour if required. If the categorization is mild or moderate, that is child has breathlessness, child is agitated, and child should be considered to be transferred to a higher center if there is no response to salbutamol over a period of 1 to 2 hours, or child is developing new signs of severe exacerbation, or if child is becoming more tachypnic and saturation levels are decreasing, then we need to consider transferring. If child is improving, monitor closely, and then if symptoms recur within first 3 to 4 hours, we can give additional doses of salbutamol, 2 to 3 puffs every hour, and prednisolone can be added even in mild or moderate cases at a dose of 2 milligram per kg. At any point of time, if child is worsening or failure to respond to 10 puffs of salbutamol, consider transferring to the higher level, that is ICU. If child is improving, discharge should be planned with a proper follow-up care, that is child should continue to have reliever as required and controller. It can be considered if required, adjust the dose and then a regular controller can be added, and check the way the child is taking medicine, whether the technique is correct, whether the adherence is correct. If available, check the number of doses that have been used. The dosimeters are available in most of the MBIs now, that can be checked, and then cross-checked with the asthmatic diary whether child is actually taking or not. And follow-up visits need to be scheduled as early as possible. And if exacerbation is resolving, you need to check on follow-up whether a child continues to have symptoms of exacerbation or resolved, and we need to take a call on whether prednisolone should be continued or not. And asthma exacerbations in older children, more or less they are similar. Only difference is the dose of salbutamol MDIs. In case of mild or moderate, it starts off with 4 to 10 puffs with a pressurized MDI and spacer. It can again be repeated every 20 minutes for first 1 hour. And prednisolone dose is slightly higher, the maximum of 40 milligrams in children, and adults we can use up to 50 milligrams. And oxygen, if required, we can start it off if it is available with a target saturation of 94 to 98%. Whereas in life-threatening, transfer to a higher center, while we are waiting for transport, you can use short-acting beta agonist and ipratropium bromide, and systemic corticosteroids are better and well tolerated in older children. If you look at the BTS guidelines, that is British Thoracic Society guidelines, it depends on the age. 2 to 5 years, we have a different protocol as compared to less than 2 years and more than 5 years. We'll start off with the 2 to 5 years. We need to divide into moderate asthma or acute severe asthma or life-threatening asthma, as we discussed earlier. And then the first line treatment would be beta-2 bronchodilators via spacer and a face mask, and early consideration for oral prednisolone of maximum of 20 milligrams. And then acute severe asthma, we need to give SABA, that is beta-2 bronchodilators via nebulizer, preferably given through oxygen. It is not oxygen being administered from side. The delivery of nebulized solution should happen through oxygen. And a salbutamol dose, salbutamol, not levosalbutamol, salbutamol dose of 2.5 milligrams needs to be considered. If nebulizer is not available, it can be delivered using spacer. And early use of oral prednisolone or IV hydrocortisone 4 mg per kg if child is vomiting and unable to feed. It can be repeated, that is beta bronchodilators can be repeated every 20 to 30 minutes based on the response. If there is no response or poor response, add ipratropium bromide to every nebulized bronchodilator, every nebulized beta-2 bronchodilator. It also can be given every 20 minutes for 1 to 2 hours. If it is a life-threatening asthma in children between 2 to 5 years, initial management will not change. That is beta-2 bronchodilators with ipratropium. We are starting off with along with ipratropium from the beginning itself, and then we are going to add oral prednisolone or IV hydrocortisone, and consider adding magnesium sulfate in nebulized form. Consider adding nebulization of magnesium sulfate in nebulized form. If child's response is good, we need to consider bronchodilators every 1 to 4 hours as required, and then discharge when stable on 4th hourly treatment. Do not send the child home on hourly or second hourly nebulization. And we might need to consider prednisolone for 3 to 5 days. If child is not responding to beta-2 bronchodilators along with ipratropium and steroids and magnesium sulfate, we will have to consider IV magnesium sulfate, a bolus of 40 milligram per kg over 20 minutes. And then if it is available, IV salbutamol is a good choice if it was not already given. And as initial bolus dose followed by infusion also can be considered. Aminophyllin loading dose over 20 minutes and continuous infusion can be used in children 2 to 5 years. It should not be considered for usage in children less than 2 years. And for bigger children or older children beyond 5 years, acute severe asthma, beta-2 bronchodilators, oral prednisolone, it's more or less similar. If poor response, add ipratropium bromide. Whereas life-threatening asthma, we start off with beta-2 bronchodilator along with ipratropium bromide from the beginning, preferably oxygen-driven nebulization, and then we need to repeat it every 20 to 30 minutes for first 1 to 2 hours, and add oral prednisolone or IV hydrocortisone if child is not taking, and then nebulized magnesium sulfate can be given along with beta-2 bronchodilator or ipratropium bromide. They all can be clubbed together and can be given. If child is not responding, similar, we will consider IV magnesium sulfate and a bolus of IV salbutamol followed by an infusion, and IV aminophylline loading dose followed by an infusion. We need to assess response before starting each of those new therapies. If child has responded to ipratropium plus beta-2 salbutamol, beta-2 bronchodilator, that is salbutamol, we don't have to add magnesium sulfate for nebulization. And children less than 2 years, management of acute asthma in a hospital. We need to assess and record the severity of asthma, whether it is moderate or acute severe asthma. Here we are not grading into life-threatening or acute severe or moderate acute asthma. There are only two categories in children less than 2 years. One is moderate asthma as defined by saturations of more than 92%, audible wheeze, and visible use of accessory muscles, but child is still feeding. Whereas in acute severe asthma, saturations are less than 92%, child has central cyanosis, child has marked respiratory distress, and child is too breathless to feed. Most infants are audibly wheezy with intercostal retractions, but they might not look very distressed as we see in bronchopneumonia. And the life-threatening features in this age group include apnea, bradycardia, and bradypnea or poor respiratory efforts. Immediate management would be giving a trial of beta-2 bronchodilators via spacer and a face mask. 1 puff at a time, inhaled separately, and then it can be repeated every minute up to a maximum of 10 puffs. If a nebulizer is available or through oxygen driven, salbutamol dose of 2.5 milligrams, which is standard across the age, can be given, and it can be repeated 1 to 4 hours if child is responding. But if child is not responding to beta-2 bronchodilators, we will have to add nebulized ipratropium bromide of 250 micrograms every 20 to 30 minutes for first 1 to 2 hours. And oral prednisolone can be considered. And there is no enough evidence to say that nebulized magnesium sulfate or IV magnesium sulfate or aminophylline is beneficial in children less than 2 years. That is a major difference in this age group. We need to continuously monitor the child for heart rate, respiratory rate, and then pulse oximetry, and ensure that child is well hydrated. And only if there is a need, we would ask for a chest X-ray. And then the new technology, every bad thing brings up new things. Similarly, COVID-19 has brought up so many changes, be it cultural or practical or social or even technological changes that have occurred there. Telemedicine has been an effective tool even in the past for delivery of healthcare, but during pandemic, it has picked up so much of importance. It is offering caregivers a chance to receive care for their children in the comfort of their own home without causing undue overcrowding and reducing the chances of cross infections. Remote consultation clearly has many advantages that will be very important while we move forward. It includes minimizing the cross-infection risk, which is likely to be a long-term issue, and it will reduce the disruption to normal life. However, there are frequently safeguarding concerns in children because it might not always be very easy to assess the severity in children as compared to adults who can speak up. Accessibility to a professional advice is often easier through digital pathways. If you look at every act of ours is being recorded by GPS, whether what time we were at a hotel, what time we are at home, what time we are at hospital, what time we have moved across, which street we have crossed, everything is being monitored. Similarly, if we use the technology in the right way, there are electronic stethoscopes which are available, which can be linked to mobiles through a Bluetooth technology. So it is imperative to design remote monitoring systems not only to optimize the distance of OPD consultation, but also to use it to improve overall outcomes. Sometimes acute assessment of visibility when performed might have to be closely monitored. We might have to call them for a checkup if follow-up is not easy. Routine outpatient monitoring, which includes like height, weight, spirometry, these things can be monitored remotely. What is the triage approach to a patient with asthmatic exacerbation during pandemic? If child has high COVID risk but low asthmatic severity risk, then child can be tested as per the state guidelines or protocols via telehealth management, because child has less risk for severe asthma. If child has high risk for COVID and high risk for severe asthma, this child might require face-to-face evaluation. So we need to have availability of full-length PPE, and then if available, negative pressure isolation, especially if an aerosol generating procedure is anticipated. If child has low risk for COVID and low risk for severe asthma, absolutely telehealth management. If child has low risk for COVID but high risk for asthma, he would require face-to-face evaluation. It can happen at a primary level or at a tertiary level. And what are the basic protective measures? Hand wash, the first and foremost. Wash your hands as frequently as possible for at least 20 seconds, because this is very important if we have gone across to a public place. And the second most important one is practicing social distancing. This is very important to limit or slow the spread of COVID-19 as far as possible. And various countries have come up with different plans or strategies for management of asthma. This is one which was taken from Korean study. Look at the child. If child has asthma or suspicion of asthma, whether child is stable or child is a newly diagnosed status asthmaticus, that is acute exacerbation of asthma, or newly developed symptoms of asthma. If child is stable, assess the risk for COVID and treat as we would do for any other asthmatic. If child has an exacerbation, consider COVID-19 RT-PCR, and then if risk of asthma is high, immediate management in A&E, that is accident emergency or emergency room, with all practical PPE which is required while the results are awaited. If child turns out to be positive for COVID, we might have to shift him to a designated hospital for treatment of COVID-19. If child continues to have negative RT-PCR report, and then child's asthmatic management can happen in the primary hospital. What advice do we need to give for children and families at discharge? Hand wash and clean the equipment which they are using for asthma management. It could be face mask or mouthpiece or spacer or peak flow meters regularly based on the manufacturer advice, and take all medications related to asthma as prescribed. This will reduce the chances of exacerbations, which can be prevented by any respiratory virus, be it RSV or be it rhinovirus or coronavirus as well. And then continue inhaled corticosteroids, because if we stop inhaled corticosteroids, that itself is going to be a risk for exacerbation of asthma. We need to educate families and children that there is no evidence to suggest that increased use of inhaled corticosteroids will increase the risk of getting COVID-19. Always have the reliever medications available at home, because early management of exacerbation turns out to be better in terms of acute as well as long-term care. And management of acute exacerbation should not rely only on reliever medications. So prescribed personal asthma action plan needs to be followed, and continue inhaled corticosteroids. Inhaled corticosteroids are not a replacement for oral corticosteroids, especially in acute exacerbation. In acute exacerbation, child should receive either oral or systemic corticosteroids. And the device which they are used should be used as per manufacturer's requirements, and then advise not to share their inhalers or spacers with anyone, even if there is a family member who is having exacerbation. and they should follow the asthma plan to recognize and manage the symptoms, and then seek immediate or urgent medical help. They should have enough medications for his own control, but should not panic and then stock up piles of medications. Otherwise, it would be leading to difficulty for others. Always have a backup plan, either a telephone or a video or a teleconsultation or a face-to-face appointment, either with a family physician or a nearby hospital. And do not forget the government advice on social distancing wherever it is applicable, and then shielding. And what is the impact of social determinants on asthma and COVID? There are many social determinants: physical environment, including exposure to second-hand smoke, and then access to healthcare services, other than race, ethnicity, and gender, those things. There has been enough evidence to show that there is an interplay between some of these social determinants and the impact of COVID-19 in asthma. And then there is more and more evidence coming up that COVID-19 lockdown is leading to obesity, which is leading to increased acute exacerbations of asthma. And the impact of COVID restrictions, impact of education, of homeschooling, especially in the families, if they do not have organized structure. And then if school closure will increase the risk of childhood obesity, which is a known risk factor for acute exacerbations. And to conclude, in the face of uncharted territory and unprecedented times, there remains much to be learned about the impact of pediatric asthma on the course of SARS-CoV virus infection and vice versa. That is the impact of COVID on asthma also. Though the adult data has suggested that asthma is a risk factor for COVID-19 morbidity and mortality, similar studies in children have not been established or not available so far. And it's not always easy to differentiate COVID from acute exacerbation of asthma. It is a challenging situation. As a result, pediatricians and the families also have an essential role in ensuring that they maintain a good asthma control and they thereby reduce the exacerbations. Children and adolescents with asthma should remain on their routine prescribed asthma medications and practice hand washing, social and physical distancing, and avoiding the allergen exposure. And last but not least, treatment of acute asthma exacerbation should include oral corticosteroids, not inhaled corticosteroids alone. Thank you, and I'm open to questions if any.
Thank you for the session. We have questions being popped up. So I'll just take one by one and then you can address the same. So there is a first question which talks about the query is from Dr. Vijay from Vijayawada. Doctor says, in non-COVID patients, would you prefer nebulization therapy to control the symptoms?
Now there is enough evidence to say that pressurized MDIs are equal, if not more effective than nebulization. Nebulization alone, in the absence of oxygen, is more detrimental as compared to MDIs. So my answer is MDIs are equally effective as compared to nebulization. But if child saturation is less than 92, try and give nebulized bronchodilator through oxygen-driven port.
Thank you, sir. So there is one more query which Dr. Shubha Lakshmi talks from Bangalore. She says, for how long do you recommend inhaled corticosteroids in management of asthma?
Okay, I did not actually get into this topic of routine management of asthma, but inhaled corticosteroids can be used 3 to 6 months depending on child's control, compliance, and frequency of exacerbations. If child's asthma control is pretty good, and then and child is not requiring frequent relievers for exacerbations, we can discontinue after 3 months of use.
So there is one query from Dr. Shubham, who is from Lucknow. He says, as an intensivist, how do you manage the cystic fibrosis patient in current COVID scenario?
Fortunately or unfortunately, I do not have any cystic fibrosis child who has presented in last few months, but it would not be any different as a COVID child. We are treating every possible child as a potential COVID. We are maintaining the regular norms of appropriate PPE, and then wherever possible we are isolating them into isolation rooms. If they are receiving nebulizations, they are going to be in an isolation room. They are not going to be mixed with other children in the ICU. So the answer is, it would be like any other respiratory child. So he would be isolated. He would require, if required, nebulizations will be given in negative pressure isolation room if it is available, or other isolation rooms where healthcare worker should take appropriate PPE and then monitor remotely.
Thank you, sir. So there's a query from Dr. Manju from Hyderabad. She says there is a lot of confusion and no clear guidelines on usage of nebulizer. Do you recommend the use of a nebulizer in an uncontrolled asthma?
Okay, so if it is an exacerbation, the answer would be depending on his saturation levels. If it is not an exacerbation, if it is for routine maintenance of a mild intermittent asthma, reliever can be given using a MDI. Most MDIs which are available now are pressurized MDIs. So pressurized MDIs are enough to control asthma unless saturations are less than 92%. The reason being, if we are using pressurized MDIs in a child whose saturation is less than 92%, we are going to cause bronchodilation, but there will not be enough oxygen going. So we can create a ventilation perfusion mismatch. So that's one of the situations where we need to give nebulization with oxygen driven machine.
So there is one query from Dr. Jay, who is from Ahmedabad. He says, how do you manage uncontrolled asthma, and what is your preference of drug of choice?
Okay, so again we would check 5 days, that is the drug which we are giving, whether the and the dose we are using, and the delivery route which we are using, and the device and duration. Before starting a new drug, we need to check all these 5 days. So check whether we are already using an appropriate drug in an appropriate dose for an appropriate duration and the delivery device, and then check the adherence. Most often than not, so-called uncontrolled asthmatics, if we check the way the technique of taking of that medication, that itself would be wrong. So we do not deviate from GINA guidelines. We stick to these first 5 days, check, and then consider alternate diagnosis, whether the diagnosis in itself was wrong in the beginning, and then see if there are any other comorbidities. Not very uncommon to see preterm babies developing asthma will have some element of bronchopulmonary dysplasia, and they do have some amount of gastroesophageal reflux disease, and then worsened by the seasonal viruses, RSV or rhinovirus. These are the common ones which they cause to create a situation, so-called situation called uncontrolled asthma. So we start off with the short-acting beta agonist, and then if child is responding well, that's good enough. Otherwise, we start off inhaled corticosteroid, and then we can consider leukotriene receptor antagonists. So this is how our stepwise management of asthma in uncontrolled asthma would be.
So there is a question from Dr. Sridhar from Hyderabad. He says, how do you manage COVID negative patients in your hospital, as you have seen some of the patients who are admitted are COVID negative?
Sorry, can you repeat the question?
How do you manage COVID negative patients in your hospital? As mentioned by you that 30 to 40% of the admitted patients were COVID negative.
No, COVID negative children would be managed like how we would be doing either way. So if any child who is presenting with respiratory symptoms are screened, we do have a separate wards for respiratory symptom children presenting with respiratory symptoms as compared to the other children. Having said that, more and more evidence is coming that the coronavirus can present even with gastrointestinal symptoms. So all children we are considering to be possible COVID and taking all precautions for every child who is admitted. And then wherever it is possible, we are isolating them. We are not allowing the children to mix with each other. And then crowding of children is completely prohibited. We do not have any area where children could mingle, which was there earlier. All these precautions only we are taking. There is, sorry, I did not mention that we have 30% positivity of COVID anywhere, as you are addressing the question. But the incidence of COVID-19 positivity in children presenting with respiratory symptoms is not as high as that is in adults. In fact, we are seeing more children with MISC or PIMS rather than acute COVID. So the management would not differ in either way, whether a child is respiratory or non-respiratory, they will be managed with all guidelines for everybody.
Okay, so there is one query from Dr. Vijay, who is again from Hyderabad. He says that since there are guidelines which are talking about restricting the use of inhaled corticosteroids in management of asthma, but in order for the initial control, sometimes we have to prefer it. So, what should be the management in such cases?
Again, if it is an exacerbation, oral or systemic corticosteroids have to be given. Inhaled corticosteroids are not an alternative for oral or systemic corticosteroids in case of an exacerbation. But if it is not an exacerbation, for controlled, inhaled corticosteroids are required, and they are mentioned in GINA guidelines or BTS guidelines for control of asthma. So there is no alternative for that. In addition to SABA, inhaled corticosteroids definitely have to be used for control of asthma. And inhaled corticosteroids doesn't mean that it has to be given by a nebulization. They can be taken through an MDI with appropriate spacer and mask. So it has to be used.
So there is one more query from Dr. Binu, who is from Cochin. She says that what is your experience on usage of omalizumab in management of the severe cases of asthma, and for how long should it be prescribed?
I would say my experience is minimal or negligible. Fortunately, our unit, we have a protocol where we start off with SABA. We usually add ipratropium bromide initially itself, both life-threatening or acute severe asthma. And then we start off with oral or IV hydrocortisone, oral prednisolone or IV hydrocortisone based on child's feeding ability. And then we add IV magnesium sulfate very early. And then we add aminophylline. Earlier we had adrenaline, which is gone out of fashion. It can be used only if child has anaphylaxis presenting as exacerbation. So fourth line drug would be aminophylline infusion, and then rarely we have used ketamine. So we have not used any of those monoclonal antibodies for acute exacerbation of asthma. My experience from UK, we have started, we used to give IV salbutamol infusion. We used to give a bolus dose of 5 to 15 microgram per kg followed by salbutamol infusion. It is not widely available in India. IV salbutamol is not widely available in India, but if it is available, it is very, very useful, especially if it is started early on. It has got wonderful results.
Thank you, sir. Doctor?
If I can just extend the previous answer,
sure,
if
sir,
facility is available, Heliox is a good option if FiO2 requirement is low. If FiO2 requirement is up to 0.4 to 0.5, Heliox is very good option because it is a lighter gas which carries oxygen quickly into the bronchodilated airways. Yeah.
Okay.
Yes.
Thank you, sir, for answering the query. So there's a last query which we have received, which talks about can we conduct a spirometry since now it's about a winter and lot of few cases is been coming to the hospitals talking about wheezing cases have been detected. So is it safe a spirometry
Sorry, your question got cut abruptly. Is it safe to use spirometry? Is that the question? Hello? Deep Lakshmi, your voice is breaking. Is the question is use of spirometry safe? Is that the question?
Yes, sir.
Yeah.
Yes, sir.
Spirometry is safe provided the cleaning of equipment happens as per protocol.